When a female patient presents with abnormal bleeding, your absolute first step on test day is to strictly follow the clinical algorithm. You have to isolate the exact etiology based on her reproductive timeline and her hemodynamic stability. We're skipping the basic foundational stuff today and jumping straight into the high-yield decision logic you need to crush Step 2CK. Mastering these branching pathways? That's literally the difference between blindly guessing and instantly knowing the next best step in management.
So first things first, if your patient is of reproductive age and has abnormal uterine bleeding or secondary amenorrhea, you must immediately order an HCG level. This branches your logic right away and do pregnant versus non-pregnant pathways. Never, ever assume a patient isn't pregnant. Once you have that HCG result in hand, you layer on the other key variables: gestational age, hemodynamic stability, the presence or absence of pain, ultrasound findings, cervical os status, and uterine tone. Doing this instantly narrows down your differential. Think of this as your universal bleeding framework.
Let's say your patient is definitively not pregnant, but she's got heavy bleeding. What's next? Well, contrast a uniformly enlarged, tender globular uterus, which points straight to adenomyosis, against an irregularly enlarged uterus with uneven contours, which is classic for uterine fibroids. And keep in mind, adenomyosis typically shows up in multiparous women over 40. You also need to distinguish between endometrial polyps, which usually present as intermenstrual bleeding, and endometrial hyperplasia or cancer, which show up as irregular or heavy bleeding, often driven by unopposed estrogen. Oh, and don't forget the outliers. If you see a patient with heavy bleeding, a completely normal-sized, non-tender uterus, and a history of easy bruising or mucosal bleeding, you should immediately be thinking about a coagulopathy like von Willebrand disease.
Now, what if the patient presents with postmenopausal bleeding? Your non-negotiable first step is a transvaginal ultrasound, period. If that endometrial stripe measures greater than 4 millimeters, you absolutely must proceed to an endometrial biopsy to rule out endometrial hyperplasia or cancer. And here's a crucial test day caveat. If that biopsy comes back non-diagnostic, but the bleeding just keeps happening, your next move is a dilation and curettage, or a hysteroscopy, just to be absolutely certain nothing sinister is being missed.
You'll want to memorize these strict age cutoffs for endometrial sampling cold. If the patient is age 45 or older with abnormal uterine bleeding, an endometrial biopsy is always indicated. It literally does not matter if they are pre- or postmenopausal. Now, for patients under 45, they only need a biopsy if their bleeding is coupled with risk factors for unopposed estrogen, things like obesity or PCOS. Or you'd biopsy if they've failed medical management, or if they have a known genetic predisposition like Lynch syndrome.
All right, shifting gears to early pregnancy. If a patient comes in with first trimester bleeding, abdominal pain, an empty uterus on ultrasound, and an HCG above the discriminatory zone of about 3,500, that is an ectopic pregnancy. Staple patients get methotrexate, though remember that's strictly contraindicated if they have renal or hepatic disease. Unstable patients go straight to the OR. Now watch out for a vignette describing a snowstorm ultrasound, hyperemesis, early preeclampsia, hyperthyroidism, and a uterus that is way larger than dates. That's a molar pregnancy. You manage that with suction curettage, tracking serial beta-HCG levels, and strict contraception for 6 months. And if they later develop postpartum bleeding with lung metastases, think choriocarcinoma. Now, if the pregnancy is intrauterine, you categorize spontaneous abortions by looking at 3 things: the cervical os, fetal cardiac activity, and retained products. A closed os means a threatened abortion if cardiac activity is there, a complete abortion if everything is expelled, or a missed abortion if there's no cardiac activity and products are retained. An open os? That confirms an inevitable abortion if products haven't passed yet, or an incomplete abortion if they are partially retained.
Picture this. You have an abortion accompanied by a fever, a boggy, tender uterus, and a dilated cervix with sanguinopurulent discharge. This is a septic abortion, and it requires immediate IV fluids, broad-spectrum antibiotics, and suction curettage. This is an absolute medical emergency. You cannot wait around for cultures to result. The retained products of conception are essentially acting as a nidus for a severe infection. This often happens following an elective abortion with non-sterile technique or after a missed abortion. Urgent surgical evacuation is your definitive treatment here.
Okay, if there is one cardinal rule in obstetrics you take away today, it's this one. If vaginal bleeding occurs after 20 weeks gestation, you must never perform a digital cervical exam until transabdominal and transvaginal sonography confirm the exact location of the placenta. I repeat, do not check the cervix. Blindly inserting your fingers into the cervical canal when a placenta previa is sitting right there can cause a massive catastrophic maternal hemorrhage. Always, always look before you touch. When you're evaluating a third trimester bleeding vignette, immediately divide your differential into 2 buckets:
Bucket 1, painless bleeding, which includes placenta previa and vasa previa. Bucket 2, painful bleeding, which includes abruptio placentae and uterine rupture. This simple binary question of does it hurt is a massive shortcut that will essentially solve the clinical vignette for you right away. Let's quickly break down each of these 4 critical diagnoses.
Starting with the painless side, if the ultrasound diagnoses placenta previa, you're going to see the placenta covering the internal cervical os. Risk factors to look out for include prior cesarean sections, other uterine surgeries, and multiparity. Stable management includes pelvic rest, absolutely no intercourse, and a scheduled cesarean delivery at 36 to 37 weeks. If she's stable with just mild bleeding, we manage with IV fluids and observation. But if she develops active, severe bleeding or becomes hemodynamically unstable, you completely bypass the schedule and proceed to an immediate C-section.
So how do you distinguish vasa previa from placenta previa? Look for painless bleeding that occurs exactly simultaneously with the rupture of membranes or contractions, where the fetal heart tracing suddenly shows bradycardia or a sinusoidal pattern. If you see this specific combo, suspect vasa previa and go straight to an emergency cesarean delivery. What's happening here is that unprotected fetal blood vessels are tearing, not the maternal placenta. Because the blood loss is entirely fetal, it rapidly leads to fetal exsanguination and demise.
Moving over to the painful side of our differential. If a laboring patient with a history of a prior cesarean section experiences sudden, sharp abdominal pain, you can suddenly palpate fetal parts right through her maternal abdomen and there is a sudden loss of fetal station, that's a uterine rupture. This requires an urgent laparotomy and delivery. The key giveaway here is the previous C-section or myomectomy scar giving way. You're also classically going to see fetal bradycardia or sudden decelerations on the monitor alongside irregular contractions.
What if the patient has hypertension, preeclampsia, recent abdominal trauma, or a history of cocaine and tobacco use? If she develops sudden, painful bleeding and high-frequency, low-intensity contractions, think abruptio placenta. On exam, the uterus will feel distinctly rigid and tender. Now keep in mind, the maternal hemorrhage might actually be totally concealed behind the placenta, meaning she could present without any visible vaginal bleeding at all. Initially, you manage the hemodynamically unstable patient with IV fluids and left lateral decubitus positioning. Why left lateral? It displaces the heavy uterus off the aortocaval vessels, which maximizes cardiac output to keep her stable while you prep for delivery. You'll be monitoring very closely for fetal hypoxia and maternal DIC.
Let's talk PPRUM, preterm pre-labor rupture of membranes. Your evaluation begins by confirming pooling, nitrazine-positive fluid, or ferning before 37 weeks. Management then totally depends on gestational age. If she's less than 34 weeks and the fetal status is reassuring, she gets latency antibiotics and corticosteroids to help with fetal lung maturity. But if there is non-reassuring fetal status or any clinical signs of infection, that requires immediate delivery. Specifically, if you see chorioamnionitis, which is marked by maternal fever plus fetal tachycardia, maternal leukocytosis, or purulent fluid, that's a game changer. It requires immediate broad-spectrum antibiotics and delivery, usually via induction unless there's some other obstetric reason to do a C-section.
When evaluating intrapartum or postpartum emergencies, remember that chorioamnionitis requires delivery regardless of gestational age. Now, looking at postpartum bleeding, you need to differentiate normal lochia from major red flags, like soaking 1 or more pads per hour for at least 2 hours, passing large clots, or presenting with symptoms of anemia. Postpartum hemorrhage has strict definitions. It's greater than 500 milliliters of blood loss for a vaginal delivery or greater than 1,000 milliliters for cesarean. Also, in that immediate postpartum phase, be highly vigilant for placenta accreta. This is strongly linked to a history of prior cesarean deliveries combined with placenta previa. It presents as a firm uterus with a morbidly adherent placenta that just will not separate normally. If you attempt manual extraction, it's going to cause massive hemorrhage. Antenatally diagnosed cases require a carefully planned cesarean hysterectomy.
Finally, let's talk about the physical exam of the uterus, because it tells you exactly what to do next. If you encounter massive postpartum hemorrhage and the abdominal exam reveals an absent uterus, but you see a round mass protruding through the cervix, you are dealing with a uterine inversion. You must provide aggressive fluid replacement, manually replace the uterus back into the pelvis, and only then give uterotonic drugs. Giving uterotonics too early clamps the inverted uterus down, making it literally impossible to replace. Contrast that absent uterus with a soft, boggy uterus, which indicates uterine atony, or a firm uterus suggesting retained placental products or incomplete separation, or even a contracted uterus with continued bleeding, pointing to trauma, laceration, or DIC.
For uterine atony, you immediately perform uterine massage and give high-dose oxytocin and tranexamic acid. If you have to move to second-line uterotonics, know your contraindications cold for test day. Methylergonavine is strictly contraindicated in hypertensive patients, and carboprost is strictly contraindicated in patients with asthma. If medical management fails, you step up to balloon tamponade and finally laparotomy.